plastic surgery, Bloomfield Hills, Michigan, and also northern suburbs of Los Angeles, California. Warm welcome to all our new members. A lot of developments over the last week. And so very happy to state there was another nice case that I did at the hospital, as you saw earlier today. This was a nice patient with a high BMI, and because of her underlying comorbidities, I ended up doing the surgery at the hospital. She had implants silicone 2005. What was noted on an MRI, one side to be ruptured, which was the left side. And lo and behold, the right side was also ruptured. Her MRI was done almost 2 years ago. And this is where you never know what you're going to find. And so I just want to go ahead and start off by saying this entire surgery is all about two mindsets. The first mindset is that breast implant illness exists. It is a real entity. Implants have been banned before in 1992 till 2000 and latter part of 2006. Implants certainly indeed cause a lot of hurt. There is something called breast implant illness. It truly is a real entity. If you go to the breast implant, certain labeling recommendations to improve patient communication, guidance for industry, Food and Drug Administration staff, issued September 29, 2020. It should say guidance for patients. And as you will see, there is this on page 9, the black box warning. It says, patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. So right off the bat, they're telling you that it does exist. Individual patient risk for developing these symptoms has not been well established. Some patients report complete resolution of symptoms. Complete resolution means cure of symptoms when the implants are removed without replacement. So they're telling you it does exist. And that the surgeon must be a firm believer in breast implant illness. And that's where and how he or she is going to do the operation. If you don't believe in something, how are you going to carry out the operation? If you're still putting in implants, how are you going to carry out the operation? And it has to be done systematically, thoughtfully, consistently, because the surgeon believes, yes, the MRI said the left side was ruptured. I always assume that both of them are ruptured regardless of what the MRI says. Remember, the MRI is a good indicator as to what one is going to find, but not the perfect indicator. It has false positive, false negative, and the best imaging modality is the MRI without contrast. No radiation, no contrast, and this is a very defined way to basically pick up on what is a rupture. And again, if you go back and look, we have none of whatever I'm going to say is my opinion. It is objective evidence, and that's why I have, this is the mentor advertisement. You see the same black box warning right here. This is the advertisement for mentor, as you can see right here. And then it says over here at the middle of the paragraph, MRI screenings are recommended 3 years after initial implant surgery and then every 2 years after to detect silent rupture. Silent rupture means that the patient does not know that she has a rupture and that only the MRI would pick up on what is a rupture. And this is where the ultrasound is better than nothing, but not the test of choice, and neither is the mammogram. And the point here is the surgeon has to believe the mindset. That's the most important thing, that it does exist. The surgeon is not putting in implants. His partner or her partner is not putting in implants, that there is a firm belief in breast implant illness and that the surgeon is talking about it. Because remember, you don't have to be passive or be quiet, meaning you have to help the many other patients understand. And remember, these are not guidelines from anyone but from the manufacturers and also from the FDA and from the plastic surgeons who've been dealing with implants. And so this is the mindset of the surgeon. So that is by far extremely important, because if your surgeon does not believe in breast implant illness, how is he or she going to remove implants? There is another surgeon, for example, who initially came out and she said, I'm not going to put in any implants. Now she's putting in implants because it is too fruitful financially to be basically not putting them in. It is the first or the second most common plastic surgery procedure that's done. And every year, approximately 400,000 patients in the US get implants, as you can imagine, and worldwide, almost 2 million people. And that is a significant number. Now, what is interesting is there is no true informed consent by these patients who are getting implants, because if you were to read to them the side effects of the implants, you would only be convinced otherwise. That why would anyone even think about? The first thing that the black box warning says, breast implants are not considered lifetime devices. The longer people have them, the greater the chances are that they will develop complications, some of which will require more surgery. Some patients within a year, some patients within 3 years, some patients 15 years later. Because remember, on average, they last 10 years plus minus. Now, going back to the point, the mindset of the surgeon is critical, and it has to be pure, sincere, thoughtful. It has to be very defined and very respectful of the whole process. And remember, it has to come from the surgeon who truly, genuinely cares. And you will be able to make sense of it, because you will be able to comprehend, be it in-person consultation or be it on social media. And remember, you have to talk to the surgeon directly, not the physician assistant or the nurse practitioner, not the front desk or the medical assistant or the office manager. You have to talk to the surgeon directly, and you have to get that direct feedback from the surgeon. So in my practice, as you will see, it's a concierge type of a service where from the beginning, you get to see and talk to me, be it on a phone consultation or be it an in-person consultation. And number one, that's the direct feedback you have from the surgeon, because that way you want to get that peace of mind. And the second thing is the skill set, meaning the surgeon is first the believer, complete, sincere, and honest. What I've said in the past, one free soldier is better than 10 hired ones. You cannot hire someone to do the surgery or because they want a service. You have to have the surgeon do it from his or her heart, completely, wholeheartedly. And number two, you have to have the surgeon who has the skill set. So there are many surgeons who go in and say, yeah, I'll try to remove it. But when the going gets tough and the tough gets going, the capsule is unfortunately left behind by these surgeons because they're not firm believers, or they cannot do it even if they want to, because it is a very meticulous, involved, invasive surgery. And this is where the surgeon also has to, as mentioned, the skill set, not only the mindset, and the two have to go hand in hand. And not only that, the ultimate way that this translates out to in real life is the surgeon has to show the high definition pictures and videos of the chest wall showing complete removal of the capsule. The chest wall, not on the cutting open of the table, which we see a lot of surgeons do on and off when they do an easy case. It has to be consistently from one patient to the next. High definition pictures and videos of the chest wall showing complete removal of the capsule. And then the other half, which is less important, cutting open of the implant capsule on the table. And if you join these three together, you have what is the direct feedback to you as a patient, as a consumer, that peace of mind and confidence and the tranquility that the surgery was done in the manner described. I have seen a lot of examples where the patient said, the surgeon said that this is a HIPAA violation. It's not a HIPAA violation if you show your own patient's chest wall showing complete removal of the capsule. Today I had a patient that came in and she said to me, you made me look at my chest wall. And I said to her, I want you to look at your chest wall for two reasons. Number one, you know the invasiveness of the surgery, so you're going to be very compliant in your T-Rex arm movements, so that you know the intensity of the surgery, you know the extent of the surgery, the depth of the surgery, the extensive dissection all the way medial to lateral showing complete removal of the capsule, so that you're going to be very much compliant with the post-op instructions. And number two, you will know exactly what you signed up for. Because if you don't see your chest wall pictures, you will not be able to be convinced that the entirety of the capsule was indeed very much removed. And this is where you must demand, ask, and consent on the form that you must get the high definition pictures and videos. There are a lot of surgeons that I have talked to who go into the case with a good heart, and the next thing you know, they say the capsule was super thin and they cauterized the capsule and they put drains in and irrigated it thinking that this is good enough. Remember, the capsule and implant are at the bottom over time, but that capsular tissue that's in the upper part of the chest must be equally removed. Because if that capsule is left behind, this is an incomplete surgery. It has to be physically removed. And that is the gist and essence of the surgery. So if you go to the case that I took care of, the nice patient from Oklahoma City, and she has the high definition pictures and videos that I will show her so that she can clearly see the entirety of the implant capsule was removed in the end block fashion, and that there is no bad tissue remaining behind, and that all of that capsular tissue was removed. And this was the end block that was done, and I did the Facebook Live. And if you put the two and two together, you will have that peace of mind and tranquility that everything was removed in the manner described. And this is the transparency we're talking about. Unfortunately, in today's world and age, I've talked to a lot of patients. They meet many surgeons who unfortunately cannot give them the high definition pictures and videos. And this is what is supremely important for the patient to get that peace of mind that all of that capsular tissue was removed. Another way to check that your surgeon is doing the right surgery is, and relatively real quick, number one, the surgeon is returning the implants to you so that if you have saline implants, they were not damaged on the way out. So that's number one. Number two, the diameter of the implant dictates the length of the incision. So if you have a 500cc implant that is removed from 2.5 or 2 inches, it's virtually impossible, because how can you dissect all the way up? So the diameter of the implant dictates the length of the incision, and an incision that's going to hide in the crease where the breast tissue is not touched, and it is all, if the implant is below the muscle, the entire dissection is done below the muscle. Number three, the length of time is approximately 4 hours. So this is not the length of time, which is 2.5 hours, like another surgeon where the fat grafting was done, a lift was done, and an explant was done. It is virtually impossible. There is another surgeon who did a supposed end block in 1 hour. It is virtually impossible. I wish I could do that, so I could do 6, 8 of these in a day. I can only do 2, maximum 3 in a day. So the 4-hour surgery. Number 4, the capsules must be sent to pathology. And that in itself is proof that the whole capsule was removed. Most of the surgeons that I have talked to, my acquaintance plastic surgeons, they don't want to send it off because now they know it was a small 3 by 5 centimeter capsule that was removed. That in itself is proof that the whole capsule was not removed completely, because that is the ultimate proof. If you go to the pathology department, you can then see that capsular tissue was just removed partially and the rest of it was cauterized. And that's why the surgery was relatively faster. And so the capsule must be sent in its entirety to the pathology department, because that's the ultimate proof that the entirety of the capsule was removed. And number 5, high definition pictures and videos of the chest wall. I cannot emphasize this enough. This is where your surgeon, before you even know it, they're airdropping the high definition pictures and videos of the chest wall showing complete removal, and that they are showing you with complete transparency that this is what was done. And 6, the social media presence online is key, because remember, on my Facebook page, I have thousands of patients that can direct message each other, and I won't even know that they're even talking. There are patients that are in Florida that they know exactly what happened in California. This is how good of research that they have done talking to the other patients. And the patients are certainly very well equipped mentally in regards to being able to comprehend the nature of the surgery. There are so many patients who are not even in medicine, who are stay-at-home moms, who are librarians or physicists, or even internal medicine doctors who have no concept of surgery. And these are patients who truly understand and comprehend what the surgery is about, because they follow me. And there is no other better way than to go on YouTube, our Facebook, join the webpage, and then not only learn to what I'm saying, like from a Facebook Live such as this, but more importantly, talk to my previous patients. Now, over the weekend, there was another concern that one of the patients, having talked to my phone consultations, another patient voiced the concern about like the cost of the surgery. Now, I have been told by so many patients I am undercharging for the amount of time I'm spending with my patients, not only in pre-op, post-op, but during the surgery in itself. These are patients with ruptured 800cc implants. So let me give you the perfect example. This last week, I did a case where she came in and she had what was a set of implants, she said, that were in the 375 range. And this was a set of implants where this was sitting on the chest that had bottomed out significantly. When I ended up doing the surgery, it turns out that she has 600cc implants. And so significantly larger than the 500. And that there is significant contouring that needs to be done in order to make that very asymmetric right side symmetric to the left side. And she had what was a significant overhang on the right side compared to the left. And there was exact measurement from the nipple down to the crease on the right and also on the left, so as to make it symmetric, so that if it was 6 centimeters from the nipple down to the crease on the right, there was more skin cut on the left, so that not only would she not need that unnecessary lift, lollipop anchor incision, or the S lift or the J lift, but she would also not be getting any cuts in and around the nipple areola up and down, and she would only benefit from what is that pseudo lift. So there was a significant size discrepancy compared to what she said before and after, and also the significant contouring that certainly adds overall to the case, where to the point she would not need a formal lift. And this is where that extensive time comes into place. I took care of another patient. She had 225cc implants, very relatively simple case, straightforward, below the muscle, one set saline. That is what is, I would call, a tier 1 category. Automatically, this patient falls into what would be a tier 3 category. And this is where it is the length of time plus the complexity of the case plus the extensive contouring that adds overall. And we're very transparent, so the patients know exactly what they're signing up for and how and why the surgery was done, because they have the high definition pictures and videos. And this is where it should not come as a surprise for the patients, because there are patients who signed up and they thought that the implants were ruptured, and lo and behold, they were not. And I ended up refunding the money to them so that they knew exactly what the refund was, because there are a lot of unknowns going into the case. Now, what I want to do is, please feel free to ask any questions. Mar, if there are any questions that we have, I'll be more than happy to answer. Please ask me directly the questions and I'll be more than happy to answer. If there is any questions or I'm not sure, I'll be the first person to state I'm not sure. So please go ahead and ask me any questions.
Okay, so far none on there, but I do have some previous questions. Why would 3-year-old silicone implants become white and cloudy on the inside?
So I have seen this happen where a patient got radiated, and now the radiation is relatively so strong, it not only burns the tissue, but on this one patient, that silicone, basically the inside of which changed its color compared to the other side that was not radiated. I've seen this happen where I did a case earlier in the year, and this was a nice patient. She had implants from 2021, just 4-year-old set of implants, and the right one, to my total surprise, was ruptured. And whenever there is a rupture that occurs, you will see that implant turns a little bit more yellow, cream, different color, as if it's starting to break down. And this is where you will see almost all the implants that I have done, that I have removed, that were ruptured. They are more yellow and different color than the other side, which is the normal or the healthier side. So the implants certainly are not lifetime devices. and they do change color because of the way they break down over time.
Question from TikTok, can implants cause a chest rash?
So absolutely. Remember, this is if you go to my YouTube page, there's a type 1 diabetic who came in and she had a very extensive rash directly over the breast tissue area, exactly where the implants were sitting. And this was what was a hypersensitivity reaction to the implant in itself. And you could literally make out the contact area where the implant was sitting and causing this disturbance. So there are a lot of patients who say that the entire chest breast area is where they have had a lot of rashes, including other parts of the body. And so this is, remember, the body's own way for picking up on what is a foreign body reaction, and the body in itself recognizing this entity as foreign and hence reacting to it and hence forming a rash, which is the dermatitis, which is the inflammation of the skin causing this reaction.
How often do you have to replace your implants?
So on average, implants are not lifetime devices. Anecdotally, if you ask me, the patients stayed anywhere from 7 to 10 years, plus minus. Now remember, they're telling you, as I read earlier, they want an MRI at year 3 if you have silicone implants at year 3, and then every 2 years they're onward. On average, plus minus 10 years. So if a young patient, 22 years of age, gets implants, silicone at 32 plus minus, 42 plus minus, 52 plus minus, she's changing these implants because they are certainly indeed very much not lifetime devices. Now, I want to go ahead and take this question, and let's look at the same verbiage exact. Again, breast implants, certain labeling recommendations to improve patient communication. Risks of breast implant surgery. I understand. Now they want you, patient initials, the patients to sign. I understand that there are risks of undergoing breast implant surgery. I understand that risks of undergoing breast implant surgery may include breast pain, skin or nipple areola sensitivity changes or loss, asymmetry, impact of aging or weight change on the size and shape of the breast, infection requiring possible removal of the implant, swelling, scarring, fluid collections, hematoma, tissue death, inability to breastfeed, complications of anesthesia, bleeding, chronic pain, damage to surrounding tissue such as muscle, nerves, blood vessels. And then if you go to the next page, it says, I understand that the long-term risks of breast implants include painful or tightening of the scar around my implant, that's capsular contracture, rupture or leaking of the implant, wrinkling of the implant, visibility of the implant, shifting of the implant, need for reoperation. And so this is where, as you will see, the next line, I understand that all breast implants contain chemicals and heavy metals. I understand that most of these chemicals stay inside the shell of the implant, but small quantities have been found to diffuse gel bleed through the implant shell of the silicone gel-fill implants, even if the implant is intact and not ruptured or leaking. This is huge, and they want your patient initials. And then at the very top of this page 14, not my words, I did not write this, and neither did ChatGPT. This is FDA. It says, I understand that silicone can migrate from an implant into nearby tissues, chest wall, lymph nodes under the arm, and organs, liver, lungs, where it may not be possible to remove. The other thing, I understand that all breast implants can interfere with mammography and breast exams, which could delay the diagnosis of breast cancer. This alone in itself should be a reason to not get breast implants. Remember, 1 out of 8 or 9 women will get breast cancer. And so this is, again, I will read, I understand that all breast implants can interfere with mammography and breast exams, which could delay the diagnosis of breast cancer. Mammography can also cause the breast implant to rupture or leak. I should tell the mammography technician if I have breast implants. So it tells you that breast implants are, quote unquote, not benign devices, and there are defined, very clear risks involved with them.
Is there anything you can do to fix a concave chest?
So this is a very good question. As you can see, those patients, especially that have a low BMI or very tight capsular contracture where the implant is literally sinking into the chest, there is a contour deformity that occurs, sometimes more, sometimes less, sometimes not at all. And now, because of the constant pressure on the rib by the implant, it causes a concavity effect. Now, when the implants are removed and the burden, the pressure of that implant on the rib that's constantly remodeling is gone, you will see the rib cage expands upward and outward whenever someone takes a nice deep breath. And as you will see, that indentation over the next 3, 5, 6 months, a year, year and a half kind of expands out. That in itself helps with the contour deformity. Now remember, majority of the times the implants are placed below the muscle, so that muscle is cut. So that muscle truly has not been utilized over the years. Because anytime you start moving your arms and use the pectoralis major function, you will only compress the implant underneath and compress against the rib, and it will be an awkward feeling. And just like a male bodybuilder bounces their pec muscle around, you would be bouncing your breast implant around, and this is that dynamic movement of the because of the muscle movement. And so you have atrophy of the muscle as well, let alone the cutting of the muscle, which compromises the muscle function. That's why the bodybuilders get the implants above. So you will see that contour deformity certainly improves because there is no mechanical pressure on the rib cage. The other thing to mention here is, with the implant gone, now the breast tissue, which atrophies as a result of the proximity of the breast tissue being next to the implant, now the breast tissue gets a chance to breathe, expand out, since it's not competing for the limited space, and you will see the breast tissue fluffs out over time. And so between the concavity, fluffing effect, the 5, 10, 15% muscle mass as patient add to their pec minor and the latissimus deltoid serratus, and between the recoil of the skin. Remember, anytime you take full thickness skin, especially on a young person like 30 or 25 years of age, it shrinks, contracts, retracts by almost 30 to 40%. So you can see that in itself, with the implant being removed, that in it basically helps with that recoil of the skin. And with the gravitational pull of the implant down as a result of the implant pulling the breast tissue down, you will see the breast tissue inevitably recoils up. The younger you are, the more so it does. And between all of these 5 modalities, you will see the patients aesthetically do very well. And number 6, that excess skin that I remove in my Facebook Lives, as you will see. And then the medial and the upward movement of the breast tissue, which is the Kandakai pseudo lift. Most of the patients do not need that unnecessary formal lift. No cutting around the nipple areola, no cutting up and down. And the patients overall do extremely well when it comes to their aesthetics. Almost 80% do not need that unnecessary lift.
Question from TikTok. Would you recommend removing implants only, or do you do a lift at the same time? Should you do a lift later on?
So I will say this to you, just like I said, majority of the patients, the 55-year-old with 350cc implants and with these 5 removal of the excess skin, the recoil of the skin, the fluffing effect of the breast tissue now that the implant is gone, between the 5, 10, 15% muscle mass you add to your chest, between the inflammation subsiding and the gravitational pull of the breast tissue down, 80% of the time, most of my patients are very pleasantly surprised that they do not need that formal lift. And you do not want to do a surgery where you may not need it. You may not want to do a surgery that may lead to more complications. There are reports by some patients done elsewhere at another plastic surgeon's office where too much was done, and now they ended up having nipple necrosis. Remember, I love to operate. I wish I was operating right now. But no unnecessary surgeries, no unnecessary cutting around the nipple, no cutting up and down. You will see a lift operation is a relatively invasive operation. I want each and every one of you, whoever is listening, to go to YouTube and type in mastopexy lift operation. And I want you to see how involved, lack of a better word, barbaric, involved that operation is, cutting around the nipple areola up and down. You will see there are some patients that report loss of nipple sensation loss of sensitivity, pins and needle sensation around the nipple. Some patients cannot nurse or breastfeed. Some patients have hypertrophic or hyperpigmented scars or hypopigmented scars around the nipple areola as a result of cutting around the nipple. Some patients report that they feel irregular masses, densities, nodularity, scar tissue underneath, and now their self-monthly breast exam is altered, or their mammogram is now altered because now they find what are these irregular consistencies on the mammogram and now an unnecessary biopsy. And for that reason, fat grafting is an absolute no in my practice, because some of the fat will inevitably die and form clumps of dead fat, and now it will get picked up on a self-monthly breast exam or on a mammogram, and you do not want to be doing something that will ultimately lead to more anxiety. Because remember, 1 out of 8 or 9 women will get breast cancer in the US, and you do not want to compound the process of screening for breast cancer where you now have some changes on the mammogram reported in 5-10% of the patients, depending on how the fat grafting technique was done. Remember, fat grafting, even in the best of the hands, will lead for a good part of the fat. Some textbooks report 30, 40, 50% of the fat will get resorbed. You have to get multiple procedures. Sometimes the fat will take on one side and not on the other. Now you have indentations, irregularities, and sometimes acute and chronic pain. So fat grafting to the breast tissue, in my practice, I call malpractice. Bad medicine malpractice, because now you're basically obscuring, compounding, complicating the screening for breast cancer, be it a mammogram or a self-monthly breast exam.
Question from TikTok: what treatment do you do for patients who had a mastectomy and implants for 20 years? Is it like aesthetic flat closure or a deep flap?
So aesthetic flat closure. So this is where the goal of the surgery is to remove not only the right and left mastectomy scars, because remember, where the implant is removed, usually it's nice sized 600 or so cc's, along with 85% of the time, plus minus, there is alloderm, which is cadaveric skin that's used. Sometimes I've seen ethibond permanent suture that's also used. Anything for an abnormal, irregular is also removed. Remember, if you have had implants for 20 years, relatively small chance, but a realistic chance that 1 out of the 2 implants could potentially be ruptured. Look at the case I did today, 2005, 20-year-old set of implants. Both of them were ruptured from the case that I did today. So there is, you have to go in with an aesthetic flat chest closure. Now, in order to get what is the deep flap, which is the DIEP, and you can certainly Google this, deep inferior epigastric perforated flap, which is the DIEP flap, which is a very involved surgery where they take the fat from the belly, including the skin, and then move it up here into the chest area and recreate the mound, i.e. the breast tissue itself. You get a tummy tuck out of it. Remember, this is a very involved operation, anywhere from 6 hours to 12, 15, 18 hours, 22 hours long that I've seen. And this is a very involved operation, and you have to do your homework, talk to the microsurgeons who do it. They're usually involved at a major hospital setting with an ICU setting, because you have to be monitored in the intensive care unit post-op. And this is a surgery in itself done only by select surgeons at any major hospital. You will never get the surgery at a private plastic surgery setting such as myself.
Why don't other doctors make women wear a binder in addition to the compression bra?
So I will tell you, this is plastic surgery 101. Anytime you get a thigh lift, arm lift, tummy tuck, gynecomastia, male breast surgery, you have to have a pressure garment. Look at the Marina garment industry, right? This is a company that's based out of post-op compression garments. And let's say if you get a tummy tuck or arm lift, thigh lift, or gynecomastia surgery, you have to wear the compression for 6 weeks. So in my practice, just like this, when you wear the bra, you will see that the bra holds your chest breast tissue area nice and comfortably tight. And then the binder kind of gives you a push up, so that when you are on your nice bumpy car ride here in Detroit, the nice roads of Detroit, there is no movement up and down. You don't want the shear forces. Just like after a tummy tuck, you do not want to be moving about and causing shear forces. If your surgeon does a tummy tuck and does not put the pressure garment on, malpractice. If you get a thigh lift and you don't get an ace wrap or a garment that you wear all the way from your below the knee all the way up into your hip, malpractice. After explant surgery, if you're not wearing the compression like I do, you will be done disservice and will be malpractice in my eyes, in my practice. And so the point here is, this is not where you're having drains and now you don't need it. You don't need the drains because you don't need it. So this is another very common question I get asked, not only by patients, but by many other plastic surgeons. And the top 5 plastic surgeons, almost all of them use drains. And one of them even reached out to me and said, how can you do the surgery without the need for drains where you have a ruptured 800cc implant? I said, if you can dissect all the bad tissue out in a very nice, defined, consistent, thoughtful, simple, very respectful way, like you really genuinely care from your heart, you do not need drains because you're getting all the badness out. And this is not only once, twice, consistently to the point where I have not used a drain in well over 6 years. That in itself is attestation to the fact where the drains are not required. 3 years ago, almost, I presented at the world's largest plastic surgery conference. This was the Guinness Book of World Records as to the maximum number of plastic surgeons who attended the conference in Dubai. And I presented my 1,000 explants, and I said the drains are not required. And many patients asked, I presented my 1,200cc implant that I removed without the need for drains because all the bad tissue was removed. And if you surely did not need it in the 1,200, you do not need it in the 300. How many of my patients go on Facebook, YouTube, and remember, they're direct messaging each other, right? How many of them go on Facebook and YouTube and say, well, the doc was great, but I needed drains? Zero. The only patient who would need drains is the one who says, I have to not wear the pressure garment, or I'm going to start working out prematurely. Like a patient came in today, believe it or not. She came in and she's wearing an ace wrap all by herself. She's moving her arms about like this. She's 5 weeks and 4 days out. And I'm like almost getting a heart attack. I'm telling her, please be careful. She demands she wants to get physical therapy. I'll tell you, she's set up for problems. And I don't think I'll be able to convince her that you have to follow my instructions, because remember, this is my surgery too. I put my heart and soul in this patient's recovery, but she does not want to grasp it. She wants to go off on her own way of doing things. And this is where, after a tummy tuck, you would dare not be doing that at all. And so just like after the surgery, the drains are not required. I did a nice Facebook Live almost 4 weeks ago with a nice plastic surgeon from the Netherlands. And God bless her, she was very nice, direct, and honest. And she said, I can get the implant and capsule above the muscle, that's a piece of cake. And I can get the implant and capsule down here. But when I have to dissect further up, that gets a little bit challenging below the muscle. And so what she does is she basically would cauterize the capsule, put the drain in, and irrigate, saying that's good enough for her. And in my practice, that's a big no-no. I physically remove the whole capsule because you do not want to leave the badness behind. If the silicone spills into the chest, go ahead and please watch the Facebook Live I did today on Facebook, Breast Implant Illness Support Group by Dr. Khan, or YouTube, Khan Plastic Surgery Academy. You will see that implant, if that were to rupture into the chest, now it is so caustic, it's going to weep, it's going to cause fluid buildup, and now the drains become mandatory. Because the drains are used, that in itself tells me that surgery was not done right. And I find, unfortunately, it's not only for 2-3 days, but 2-3 weeks. You see significant others, boyfriends, husbands pulling drains, and moms pulling drains. This is a big no-no. Only the surgeon should be pulling the drain, not the significant others. And going back to the point, if the surgery is done right, no need for drains, that's been consistently proven, and you have to have the high definition pictures and videos. The blood loss is less than 5 cc's in well over 99.7% of the patients, and that in itself authenticates that the surgery was done right. I talked to a patient not too long ago, and she said that her plastic surgeon said she could go back to the gym in 2 to 3 weeks, and that automatically means that the surgery is not going to be done right. Having drains in themselves can induce some fluid formation. Having a drain in, if it goes in and out, can dislodge the bacteria on the drain, can get seeded into the chest, which in itself is a big catastrophe. The drain in itself, if the fluid or the bulb syringe opens, the fluid can backtrack. And remember, this is dirty, non-sterile fluid. It can be a catastrophe to manage. So the drains themselves, number one, are not required, and number two, are themselves replete with problems, and that is an attestation to the fact that the surgery was done incorrectly if the surgeon is using drains. Now, I did a case on an 81-year-old patient. As soon as I made cut, the silicone was pouring out because she was involved in a car accident. And she came to me a month after an MRI showing free-floating silicone in her chest. That patient ended up absolutely getting the drains because that decision was already made. There was extra capsular free-floating silicone, and that automatically bought herself the drains.
Will I need a lift if I already had a lift when I had my augmentation?
So this is a good point. This weekend I talked to a nice patient. She already got her lift 3 years ago by another surgeon, and at the time of her augmentation. With me removing the implant, she already has a lift. You do not want to be doing something that, number one, will be only adding more scar tissue. A lift that may not be required may lead to complications, and a surgery that may not truly be indicated, or another surgery, let's say if it's done, now the nipple's pointing up because it was overly corrected. So the bottom line here is, in the technique that I mentioned earlier, with those 6 points that I mentioned, most of the patients do not need that unnecessary lift. Now that 1200 cc implant that I removed, clearly the patient was told she will absolutely need a lift, no questions asked, simply because of the significant size of the implant and the stretch of the skin, even though she was in her 30s.
Should I remove my implants after 10 years with no issues? There's a lot of ladies asking. I have implants for like 15, 20, 25 years. Is it safe to keep them in if they have no symptoms?
So this is a very good point. And it's a very deep question, but I will let you decide. There was a patient that lives in Ann Arbor. She came to me earlier this year, and she said she has implants for 10 years, and I asked her how many symptoms of breast implant illness does she have, and she said none. And clearly you could have no symptoms whatsoever, even though you have implants for 20 years. Remember, this is, some people have them, some people don't have at all, some people have some people have almost all the symptoms. Now, she said, I'm at the 10-year mark. I have read that they are not lifetime devices, just like I read this earlier. And she said, I don't want to be getting an MRI every 2 years, and I feel that the rate of rupture is going to go up. Now, the rough rule of thumb is this. If you have had implants for 20 years, there's a 20% chance that you will have a potential rupture. Now, it goes up significantly after some time. Remember, I said 7 to 10 years before they start becoming problematic. They are not lifetime devices. No plastic surgeon will ever tell you, or should ever tell you, that you will die with them. Now, you want to take care of a small fire versus a big fire. Now, in my practice, I read this page 14. I understand that silicone can migrate from my implant into nearby tissues, chest wall, lymph nodes under the arm, and organs, liver, lungs, where it may not be possible to remove. I understand that I understand that all breast implants contain chemicals and heavy metals. I understand that most of these chemicals stay inside the shell of the implant, but small quantities have been found to diffuse gel bleed through the implant shell of the silicone gel filled implants, even if the implant is intact and not ruptured or leaking. Now, there are patients of mine that have had saline implants, and they have had lymph nodes where they did a biopsy and showed there was silica inside the lymph nodes, and the patient had intact saline implants, not even a ruptured silicone implant. There are patients that have come to me that have a ruptured silicone implant, and they got a chest abdomen CT, And they said, by the way, you have a ruptured silicone implant. And they're like, what are you talking about? My results are excellent. I went to my local plastic surgeon and he said, excellent job. If the implants are not bothering you, and if it ain't truly broke, don't fix it. Absolute 100% wrong information. No one should be living with a ruptured implant. Otherwise, why are they telling you to get an MRI at year 3 and then every 2 years they're onward? Why are they telling you remove the implant? What is this whole concept of silent rupture? Silent rupture means that the exam is unremarkable, the patient has no pain, and lo and behold, the patient has a ruptured implant. No one should live with a ruptured implant. Now, the bottom line here is you're the boss. You make the decision about what you want, the peace of mind. Do you want silica to be embedded within the lymph nodes? Do you have to get an ultrasound of the lymph nodes to check if you have silica or not? Sometimes there's microscopic amounts. Now the other thing I want to mention here is, so let's go ahead and read recommended follow-up. So all the answers are over here, and I want each and every single one of you to read between the lines, maybe 5 times, read the whole breast implant, certain labeling recommendations to improve patient communication, guidance for industry and Food and Drug Administration staff. It should have said guidance for patients. So this is a 19-page document. So it says on page 14, a list of components, chemicals, and heavy metals is available in the patient information booklet brochure. Heavy metals found in breast implants: arsenic, barium, beryllium, cadmium, chromium, cobalt, copper, lead, magnesium, mercury, molybdenum, nickel, platinum, selenium, silver, tin, titanium, vanadium, zinc. If I'm a patient, I do not want this to be lingering in and around my chest wall, in my lymph nodes, in my armpit, axilla, mediastinal lymph nodes, in and around my capsules. And I do not want any of this to be a potential burden. Now remember, the other thing we must talk about here: risk of cancer, breast implant associated anaplastic large cell lymphoma. I understand. Now remember, they want your patient initials. I understand that breast implants are associated with the development of a type of the cancer of the immune system called breast implant associated anaplastic large cell lymphoma. Information regarding the number of medical device reports of BILCL can be found on the FDA's website. I have received information regarding the overall incident rates of BILCL and the rates as they pertain to my specific breast implant. I understand that this cancer has been reported more frequently for textured breast implants, but that patients with smooth surfaced implants have also been diagnosed. So that means if you're smooth, that there's also concern. I understand that patients with breast implants have a risk of developing BILCL within the scar tissue and fluids surrounding the breast implant. So that scar tissue is the capsule. So in my practice, as you will see, I always assume the worst, and I always want to be thorough and complete. The last year and a half, 2 years, I have had 3 patients that had CD30 positive, where there was a red flag for this BILCL. And guess what? They got their complete surgery to begin with, so they did not have to come back for completion capsulectomy. If a patient has BILCL, God forbid, and there have been almost 1,250 cases plus minus diagnosed on earth to date. If a patient has this rare lymphoma, the surgery of choice is to remove the entire implant and the entire capsular tissue completely, sincerely, definitively. So in my practice, I remove that entire implant and the capsule in end block or complete total capsulectomy, sincerely, definitively, thinking the obvious worst, because I don't want to send it off to pathology and later on call the patient up and say, you know what, that CD30 was positive. I want you to come back so we can remove the remaining part. I do it thinking that it needs to be done to begin with, so we give it the best shot. So that patient that I did today at the hospital, had she not gotten the end block, she would have had that silicone that would have spilled into the chest, and now no matter how much I washed it out, and which would only spread the silicone all the way in the periphery, and no matter how long I had the drains for, even if I had 1 or 2 drains, that washout was only going to spread the badness and was not going to help the patient. So the end block is what was the reason why she got no drains. Going back to the point, do it right, do it once, do it complete, do it thorough, do it comprehensively. Now, this is my practice, me being complete and me being thorough. And this is what I said today in my Facebook Live, and the many Facebook Lives where I've done, where I said 20 years from now, I cannot imagine anyone else doing the surgery any different because I was thorough and meticulous to complete with. Is it invasive? You bet it is. But guess what? If I'm the patient, I want the best foot forward going into the surgery. Now, the other thing I want to mention here is many surgeons, majority of the surgeons, do not send the capsule off to pathology, or they cut these small pieces because they are not removing the whole capsule. That capsule, if it's sent in its entirety, is going to be proof that the surgeon did not remove the whole capsule. You cannot take bits and pieces of the capsule saying, oh, I'm going to, because remember, you have to get different representative samples of the capsule and send it off to pathology. And so what is happening is the surgeons are not removing the whole capsule. They're not fixated into removing the capsule. They're not fixated in doing the total capsulectomy or the en bloc. They are not sending it off to pathology because that's proof they're not doing it completely. Even when they're sending it off to pathology, the easier cases, the CD30 analysis is not being done. And because the CD30 analysis is not being done, that BIALCL is potentially being missed. And now it is underreported, and which is very well established by the plastic surgery world, that the BIALCL is underreported for that reason, because no one is giving its due diligence or thought and respect. And this is where, in my practice, I always think that whenever there is any fluid, the BIALCL is a big red flag, and that fluid must be sent to cytology. If the fluid is not sent to cytology, malpractice, that's bad medicine. And the entire capsular tissue is sent to pathology, so that we have that absolute peace of mind and firm belief and commitment that, number one, all of that bad tissue, capsular tissue implant, was removed in the manner described, and all of it was tested, and certainly tested for fungus, aerobic, anaerobic as well.
Questions from TikTok. So is there a risk of cancer for having implants?
So there is the BIALCL, which means breast implant associated anaplastic large cell lymphoma is directly associated with the implants. That means that the patients not had implants, they would not have gotten the BIALCL, to the point where there is also another cancer, which is the BIA, breast implant associated squamous cell cancer, directly associated with the implants. So this has also been implicated, believe it or not, among other cancers that are involved with the implants that have yet to be reported. This is, again, by the FDA. And as you will see, if you ask me, let's go ahead and read between the lines over here. I understand that all breast implants can interfere with mammography and breast exams, which could delay the diagnosis of breast cancer. Mammography can also cause the breast implant to rupture or leak. So how many patients have I talked to? Just as a matter of today in clinic, the patient said, I have not gotten my mammography because I'm afraid of the pain. And now she's not getting adequate treatment for breast cancer. Millions of patients have had early detection of breast cancer from mammography that has been done over the years and decades. And clearly, mammography has saved a lot of patients' lives over the years. Early detection of breast cancer using mammography, and then followed by ultrasound and maybe MRI. Remember, thermography, waste of time. How many times have I ordered a thermogram? 0. How many times a thermogram is done at the breast center? 0. Do they do thermograms for lung cancer or pancreatic cancer? No. So remember, you want to do your due diligence, go and get that screening. So if you ask me, are breast implants associated with cancer? Yes, the BIA, SCC, BIA, ALCL, And because the patients are now afraid or their self-monthly breast exam is altered because they have capsular contracture, they're not doing a good self-monthly breast exam. And now that breast cancer is being picked up later. So you can see the detrimental effects of implants. And that in itself alone should be a reason to not get implants.
How do you test for the BIA-ALC or the BIA-SCC?
So you have to be, so as a surgeon, my role is to remove the whole capsule and send it off to pathology. And I write down history of breast implants, must do CD30 analysis, rule out BIA-LCL, rule out breast cancer, rule out abnormal pathology, rule out. And remember, this is the burden now on the plastic surgeon telling the pathologist, you must rule it out. So when I went to California, I called the pathologist up. This is a seasoned, wonderful A+ pathologist who really understood what I was wanting, what I required, CD30 analysis, Dr. Molani, and he documented CD30 analysis was done and he himself processed the samples. It was hand delivered through his assistant to him and he processed this in a timely fashion. One day, one of my patients said, I have a contract with this other major top 2 pathology groups in the country where they have thousands of pathologists. And lo and behold, it came back, no cancer seen. And did they do the CD30 analysis? No. And this is unfortunately how it's being missed. So when I first came here to the Bloomfield Hills location, the hospital right across from us, I reached their chief of pathology and I said, you must do the CD30 analysis on all the capsules that I'm going to send to you. He said, well, that's going to be overkill and unethical and unprofessional because I'm going to be doing a lot of this unnecessary staining with CD30 analysis. Then I asked him, do you think, in your professional opinion, you would potentially miss a BIA-LCL had you not done a CD30 analysis? And he said, you bet. I said, case closed. Guess what? I moved back to the other group and the courier, they drive to Henry Ford, to the old group, because I have more confidence in that person who wants to do it from their heart. And I have met them and they've processed literally thousands of my patient samples. And I have worked out a very nice cash only deal for my many patients that come from overseas, from Canada, from Europe, so that patients who do not have insurance, that they do not have to pay a premium price for something that we have worked out for them that would be very straightforward.
Are saline implants safer than silicone?
So this is a very good question. Remember, there is no such thing as a safe cigarette or a cigar or has a big filter. Saline implants cause the same hurt and harm as silicone implants. So if I have 1,000 patients that come to me with saline implants, ruptured saline implants, intact silicone implants, and ruptured silicone implants, and they have complaints, I'll not be able to tell who has what from their capsular contracture, signs, symptoms of breast implant illness, and there are many complaints and concerns of autoimmune or other problems. All of these are interchangeable. And for that reason, FDA, if you are listening, you should have stepped up and banned not only the silicone implants for cosmetic reasons from 1992 to 2000 and latter part of 6, but you should have banned them in reconstruction patients who had breast cancer, because they are as human as those other patients, and you should have banned the saline implants as well, because each one of these subgroups cause the same harm as hurt. No one more or less being the other. I have patients with saline implants and they had suicidal ideations. Almost all those symptoms checked off on the questionnaire that you can go find on my Facebook page or my YouTube page or my webpage, executiveplasticsurgeon.com. And you will see the other patient with ruptured silicone implants comes in with, hey, I look excellent, but my MRI showed that my right breast implant is ruptured. And so saline implants, horrible bad, as much as the silicone implants, horrible bad.
Do you require any imaging prior to surgery?
So I do not require this is a broad question. So if someone has silicone implants that are 10, 15, or 3, 5 years old, I will tell them I do not require an MRI. Now, in that case where the patient has had a first set of implants, it was silicone and it ruptured into the chest, and the surgeon just washed it, irrigated it out, and now it's spread all over. And now there are pockets of silicone granuloma, and her second set is saline or silicone. I want to get that MRI because I want to see where these pockets are, because what happens is the pockets gravitate down and now the surgeon walls them off in order to do a lift. And now when I remove the second set of implants, that silicone that has spilled into the chest now is walled off. I cannot feel it, see it, and I want to be able to remove that. And this is where the MRI without contrast will pick up on it. So I want to do the completion surgery knowing the history of the first set. So if a patient comes to me and she said, I am 55, I have never gotten a mammogram, I tell her, please get one for your own good, regardless of the surgery, because you want to screen for breast cancer, because 1 out of 8 or 9 women will get breast cancer. Now, if the patient says, I don't want to because I feel pain and I'm uncomfortable, or I feel my implant, my rupture, as you see, then I say, I honor your request, but at least get an ultrasound, or I have you primary stating that you do not have any masses. There is another patient that I saw. She has a mass. I tell her, I don't care. You have to go to the breast center and you have to get a full workup, because I want to make sure you do not have breast cancer, because I don't want to be operating on someone who has active breast cancer, because I don't want to spread it from the right to the left or vice versa, or even if it might be microscopic. So if there's any axillary masses or any masses of the chest breast area or concerns, I demand that a breast center clear the patient, because I do not want to be operating on someone who has active breast cancer. This happened almost 3 weeks ago. A patient stated that she had a mass, and lo and behold, it turns out they're concerned for malignancy. And I told the patient outright, I'm not going to operate on you at all, because you need to get that cancer addressed first. That's top priority before you even come to me for removal of the implant. Now, having said this, there was another patient from Florida that I took care of who had a mass. Lo and behold, they did a biopsy, and it turns out above the muscle is where she was noted to have breast cancer. Now, she wanted to get lumpectomy and radiation, but she had implants. And she came to me and she said, what should I do first? I said, I want to know where exactly the cancer is. And it was further up and away and above the muscle. And remember, I never touched the breast tissue. I never cut around the nipple. I never cut up and down. So in her, while she actually actively had the breast cancer, I went in, removed the entire implant and the capsule. Total capsulectomy was done. She healed. A few weeks later, she ended up getting the lumpectomy and radiation, and is going to live happily ever after, minus the explant, even though she had cancer. And remember, this is where I myself, as the plastic surgeon, I'm very much involved before, during, and after, so that every patient gets the 110% out of me. And this is, remember, your surgeon has to be investing in you heavily, verbally, time-wise, commitment from a heart and soul. Like the surgeon really cares. There are many docs, unfortunately, and I'll be the first person to say, they walk in within 3 minutes, 5 minutes, 10 minutes, they're in and out. They never get to see this patient. The patient never gets to see. They see the PA. The office manager is talking more to the patient. There is more fixation in the liaison or the representative or a patient advocate who's talking to the patient and luring the patient into signing, versus the surgeon who basically does 10, 15 minutes and said, that's more than I would ever give to you. And unfortunately, the surgery is done in like a quick in and out way, because he may have a golf game later on in the day, or another 3 more patients to do that day, because he's literally doing a job because his heart and soul is not in it. Remember, this is a surgery where your surgeon has to be genuinely, 100% honestly, sincerely involved, and that he really cares. She really cares. And you will be able to tell just from interacting with the surgeon that this is your right choice. Remember, do not rush into the surgery. Do not make a commitment. Yesterday, I did a I did a phone consultation, a patient who reached us via Facebook and a phone consultation, and she had not seen my YouTube or my Facebook. And she's like, how far are you booking? I said, don't talk to me about booking. First, you have to learn more about me. You cannot talk about booking at all because you have to indulge, you have to be obsessed, fixated into how I do it. You go to 10 different plastic surgeons, you're going to get 10 different answers. So the bottom line here is you have to do your due diligence, talk to the surgeon directly.
What should my surgeon test for? I'm having explant surgery with a different doctor in 2 weeks.
So your surgeon should test for anything bad. So whenever I talk to my pathologist, and I remember my pathologists are seasoned, they're very, very experienced, and they know what language I'm looking for.